fitting into your cohorts. But don't open those until we start the Kahoot, so we've got a couple other things to do first. Hi, Lindsay, I see you running around there. Thank you very much for delivering those. So today could be kind of interesting. We don't have any, our TA in Rochester is not there today, so we're running the whole shebang from here. So we'll see how well I do with how many balls in the air. Anyway, I have a couple things that I want to cover before we get started. First of all, any questions that aren't about the exam? Questions? Questions? Okay, and you can always send a note to Rainey and I and let us know what's going on if you have questions. Exam 2, so I put in the grades for exam 2. Those of you who put your name in correctly on your Scantron will have to wait a few days to get your scores. There were more than the first exam, and it's like I told some of the students, when we have so many students and we have to enter the grades manually, when you guys don't do last name first, it gets all screwed up and it moves you to your first name where your first name would be, and we're just entering grades, so it really makes it cumbersome and messy if we get them all in wrong, okay? So it's kind of just a self-reminder that it is really important. It's not just Rainey and I being kind of retentive, as you would say. So I did also want to let you know we aren't able to do a key room today, but we will do a key room next week, okay? I just didn't have time to get absolutely everything done and everything done for Rochester. So I don't want us to have it and them not to have it. So we will do that next week. I don't have exactly how many students had what grades, but I will tell you that the distribution was really good on the exam. So we had a nice curve. It wasn't skewed one way or the other, which is one of the things that Rainey and I look for. Yeah?
I had a question not about the test. So.
Okay, just let me run through this and then we'll come back to that. The PowerPoint for today is on Canvas. There are lots of holes in it for you to fill in. So if I'm going too fast, which is my nature, please just say, Dawn, can you slow down, okay? I want you to get all that information. And some of it, some people might be better typers or follower-alongers, or some people are writing. So just cue me, okay? The information on the PowerPoint today is information you're going to be using for the case study, but you will also have to use the ADA standards that are also on Canvas. It's like a 120-page document. Please don't try to print it. You can get to it electronically, and if anybody needs to borrow like a iPad or something, we can get some from either here in the lab or in Rochester, okay? So if you have a group where you can share, that's great. If you need one, let Lindsay or myself know, okay? We will have a role play activity at some point this afternoon, and probably not until we get mostly through the PowerPoint so that you guys have some information. And then we will spend a good amount of time on the case study. It is vital that you guys actually use that ADA standards and that you fill this out. You're not going to hand it in. That will be your ICA, and I will send out ICA sheets for you to fill out. But I will warn you, there are test questions that come directly from this case study, okay? So very important that you actually do it, that you understand what's on it, and those kinds of things. Question?
So I was just wondering about the teaching project you have to do. Is there, I know all the instructions are on Canvas, so is that just all on our own to start that and finish it and turn it in for us to do?
As far as I know, and honestly, that's kind of Rainey's gig.
Okay.
I know you guys should be starting on it. When is do you do 2 sections still, or is it just one paper?
It's just one big thing, and it's due in 2 weeks.
Okay. So Usually you'll have a time where you can set up and interview your partner, and that's going to be part of the information. So let me get with Rainey and see, we've changed it, and that's why, I mean, I did it for years, but I know that he's kind of tried to change it a little bit, so I'm not quite sure what all he's changed, to be honest. So I will let him know there are some questions so that he can get with everybody, okay? Good question. Anything else? All right, without further ado, let's Kahoot. And now you can open your Kahoot papers, and hopefully everybody in Rochester, you guys have yours. All right.
No, I think we'll read it first and then figure it out. Do this next week.
Now I feel the energy getting really low. I back up a little bit. Only have 30 players, so we need closer to 70 to get going. There we go.
Oh, hey John, we
Yeah?
need to send your computer screen to Rochester.
Can you hear that in the control room? Would they need to have my screens shared in Rochester? Hopefully someone's gonna come take care of that. Ta-da! Is that better?
All right, we're good. Thank you.
Okay, thanks for letting me know. Hi. No wonder you guys weren't joining very fast with no number. All right, looking good. You want to get on, Xavier? Okay, we're going to wait for just one more here. All right, sounds awesome. Here we go. So, first question. The nurse expects the new type 1 client to report the classic signs of diabetes. What are the classic signs? I don't have any groovy music. I'm sad. Well, let me see. I'm going to need it anyway at some point. There it is. Most excellent. Okay, good job. We call it the 3 Ps, and that will be important for you to know. All right. And next. Exercise on a regular basis has been shown to do what in a diabetic client? All right, so it does improve the cellular uptake of glucose. Although we need insulin to get it in there, the cellular uptake is also really important. All right. Increased fatigue in the newly diagnosed type 1 diabetic as a result of what? Okay, good job. So the decreased production of insulin by the pancreas. So insulin is what actually is the lock and key that opens up the cells for the insulin to actually go in, which is what will give energy to the cells. So without any energy, right, in the form of ATP, we have fatigue. So I don't have another one, so I'm sorry. I didn't count on our one extra student from Rochester, but that's all right. Okay. I will get you one, Xavier. Insulin is produced by the beta cells in the islets of flanker. Okay, it's the islets of Langerhans. Yep. Okay. All right. All right, normal glucose levels are approximately all right, so 70 to 120, and you'll find a lot of agencies or organizations will have a little bit different numbers, but generally they are around those numbers, okay? Remember that reference values are taken in each region of the country individually, so, you know, it can vary a little bit. I tried to make those definitely widespread so that really you could tell the difference between normal values and what would be considered very low or high, okay? So good to know those numbers for the next exam coming up. All right, type 2 diabetes has a sudden onset. True or false? Good job. Good job. It will be important to be able to distinguish the difference between type 1 and type 2. All right, type 1 diabetes can be caused by a virus. True or false? All right, so that is true. There are many different etiologies for diabetes, but can be caused from a virus. All right, type 1 diabetes is treated with what first? All right, so we have to treat type 1 diabetes with insulin because type 2 diabetes is where there is a decreased production of insulin. Type 1 is no insulin production whatsoever, okay? So it won't do any good to exercise or do anything else without insulin. All right, symptoms of hypoglycemia include no, those are yours. Well, here I thought I found one extra one here, but no. Okay, so here you kind of had to read carefully through them. Cold, clammy skin is a sign of hypoglycemia. However, elevated glucose kind of gets rid of that one. Okay, increase in urination and low glucose level. Usually, there is an increase in urination when it's hyperglycemic. Okay. So be careful to read those all the way. So emotional changes in cold, clammy skin is correct. All right, BT, you're cruising along. Treatment of hypoglycemia includes all right, good job. So if it's hypoglycemia, we actually need some quick-acting carbohydrates to get the glucose levels back up, okay? So that is correct. All right, prevention of hypoglycemia includes what? Prevention. All right, so here we need to take the prescribed doses of medication at the right times, okay? So prevention, just carrying fast-acting carbohydrates really isn't going to prevent it.
So it is all of them?
Oh, it's all of them.
Which one's the best?
The best answer, taking prescribed doses of medication at the right times. Okay, would be the best answer. Like I said, carrying fast-acting carbohydrates will work if you start to feel hypoglycemic and you can treat it. But the best answer probably would be take prescribed doses. Hyperglycemia is more dangerous complication than hypoglycemia. Which one is worse? Okay, so we are going to go through that today. Hypoglycemia is much more dangerous than hyperglycemia. And one of the reasons is, so if you saw the reference range for normal values, right? So we start to have problems like coma and seizures and death, okay, at right around 2030. It's incompatible with life. You need glucose to have life, right? And so there's not very far between 70 and death, right? But if you think about how high it can go, I mean, I've seen patients with glucoses of upwards of 900. They're very brittle diabetics, and usually they end up coming into the ICU and having to be on an insulin drip or things. But remember, hypoglycemia, there's much less room for error in there, okay? So the body just can't compensate, okay? Okay, this little here is kind of crazy. Oh, look at Siska. Good job. Treatment of hyperglycemia includes what? Okay, so drinking fluids and checking glucose level, we really need to bring that down. If one of the answers there was administration of insulin, if it was a type 1 diabetic, which it doesn't say up there, then that would be the best thing. Because remember, it's the lock and key that opens it up, so then the glucose would start to go into the cells instead of being out in the serum, okay? All right, here we go. The highest incidence of diabetes is among what population? Okay, Native Americans and non-Hispanic African Americans have the highest incidence of diabetes.
The non-Hispanic.
Okay, last one. Type 2 diabetics have 4 major metabolic abnormalities. What are they? Type 2 diabetics. Perfect. Good job, you guys. Always think about insulin resistance as type 2 diabetes, okay? And there is a decreased ability, but they are able to make some. All right.
And Xavier, if you will send me an email so I don't forget it, I will absolutely send you one.
Like I said, there's a lot of information, and if you are actually writing and taking notes, you probably won't have time to write down the super long lists, and don't even try. Kind of pick out the major ones, and then use those to study on, okay? And your table isn't like you have very many computers, so if we need an extra one, we can get one, okay? Oh, you have one too, Tara. Okay, all right, so here we go. So diabetes is a primary disorder of glucose metabolism, okay? So there's either insufficient insulin supply or poor utilization of insulin. It is chronic, there's no cure. It affects multiple systems in the body. It's the leading cause of adult blindness and end-stage kidney disease and non-traumatic lower limb amputations, okay? So it's very traumatic for people. It's a major contributing factor to heart disease and stroke as well. Normal insulin metabolism, hormones are produced by the beta cells in the islets of Langerhans. It's in the pancreas. It's continually released into the blood system, usually in response to when food is ingested, okay? It does lower the blood sugar, because if you think about the where we draw for our blood sugar, right, is out in the veins, right? And so if the sugar is in the veins instead of the cells, it's going to be elevated. Does that make sense? Okay. So it does lower blood glucose by letting it into the cells. Normal glucose range, think about 70 to 120. Like I said, some are a little bit tighter than that, but this would be a pretty close simile. Average amount released every day is about 40 to 50 units. Insulin is measured in units, not in cc's or milliliters or anything like that. In lab, you'll find out next semester when you use insulin needles, there is a specific needle and syringe that you need to use for delivery of insulin. And for patients who are getting a lot of their if they are eating quite a few carbs and things like that, think about, they may be getting upwards of 40 to 50 units, okay? So normal insulin promotes glucose transport from the bloodstream across the cell membrane into the cytoplasm of the cell, and that's how it lowers glucose, and we just talked about that. Now if I can get this little YouTube to work, we'll watch it's a 2-minute YouTube video.
Writing's not that easy, but Grammarly can help. This sentence is grammatically correct.
digested, it travels along the digestive tract, where it is broken down into its component nutrients in order to be absorbed into the bloodstream. One such nutrient is glucose, a simple sugar. Glucose gets absorbed by the stomach and intestines and then enters the bloodstream. It travels through the circulation to all body cells. Once absorbed into the bloodstream, glucose circulates, causing the blood sugar level to rise. An increased level of blood sugar sends a signal to the pancreatic beta cells, which respond by secreting the hormone insulin into the circulation. Insulin is necessary for glucose to reach and be used by several important target tissues throughout the body. These include the liver, muscle, and adipose tissue. Insulin is necessary to keep blood glucose levels stable in the body. Glucose enters the cell through a process called facilitated diffusion.
All right, let's get out of there. Okay. Any questions on that? Insulin is an anabolic or storage hormone. And again, this is important, a rise in plasma insulin happens after a meal, okay? Or when glucose levels go up, there is a rise in insulin. So it responds to that. The storage of glucose as glycogen in the liver and muscles. So what we aren't using right away is actually stored, okay, for use at a later time. It inhibits gluconeogenesis. So gluconeogenesis, remember, is the making of glucose out of other things, like proteins, non-carbohydrate sources. So as long as we have sufficient, we don't need to make it out of other things. It enhances fat deposition of adipose tissue. Again, remember, it's a storage hormone. And it increases protein synthesis. So it does increase protein breakdown.
So you said increases protein synthesis, so it, and also like increases protein breakdown as well?
Yep. So the synthesis would be the breakdown and building up. So it's just, and it's really because of the way that the hormone works, and it's kind of another whole part of what it does. But remember, kind of the takeaway here is that it does have actions on protein as well as carbohydrates. Does that make sense? So it's not just a glucose hormone. That's kind of the takeaway there. So normal insulin metabolism also causes a fall in insulin overnight, so that would make sense, right, when a person is fasting. And then it causes release of stored glucose from the liver, protein from muscle, and fat from adipose tissue in small amounts, just so it can feed the brain and the liver and those kinds of things. But it is available, okay? We're talking normal here, not diabetes, okay? And that's where kind of that other synthesis kind of comes in with the proteins, right? So if we have a fall in insulin overnight, it still acts and we can break down protein and use it for glucose. Skeletal muscle and adipose tissue are absolutely insulin dependent. They have to have insulin in order to work. Interesting because of how important some of these other organs are to life. The brain, liver, and blood cells do not directly depend on insulin. However, they have to have an adequate supply of glucose. Okay? Did everybody get those? Did I have too many boxes there? Okay. Other hormones that are involved in glucose management or counter-regulatory hormones. So these are the ones that work opposite of insulin. Okay? Are glucagon, epinephrine, cortisol, and growth hormone. Okay? And so generally when you see an increase in insulin, you'll see a decrease in these. When you see a decrease in insulin, you'll see an up of the others, so that it's a negative feedback system. So the etiology and pathophysiology of diabetes, so now we're moving in from what's normal into a disease state, okay? So the current theories are that there is a genetic component, and we have seen that, so they're pretty sure there's a genetic component. It's also autoimmune, okay? So that the body is attacking itself. Viruses can cause it, they believe. And obviously for type 2 diabetes, for sure, there's a link between obesity and type 2 diabetes. We're going to only be talking about type 1 and type 2 diabetes. You will learn about gestational diabetes when you do mom-baby and those kinds of things. We're just going to focus on type 1 and type 2. So there's some diagnostic criteria. And this would be actually for either type, so we're just talking diabetes now. So an A1C of 6.5 or higher. Now a hemoglobin A1C, what that is all your red blood cells have hemoglobin in them, right? And so they float around in your system for how long? How long does a red blood cell live? 120 days, okay? So remember that, that's like 3 months, right? So here these red blood cells are, and they're floating around in your blood system for 3 months, okay? During that time, what's happening is there's a glycosylated reaction happening with glucose. So the hemoglobin A1C is a reading of how much sugar your cells have been exposed to over 3 months. So like a fasting blood sugar is simply like the last 8 hours, right? A hemoglobin A1C is what's been happening the last 3 months. So it's a better indicator of long-term glucose supply and demand, okay? And so 6.5 or higher is kind of where doctors kind of get concerned. That doesn't mean at 6.5 all of a sudden you have diabetes. That does need to be repeated and it needs to be confirmed, okay? That's how. If it came up again, 6.5 or higher, then they likely would diagnose you with diabetes, okay? So fasting glucose greater than or equal to 126, fasting, okay? Because after meals, your blood sugar will go up to like 130, whatever, depending on what you've eaten. You know, that piece of cake could even go up a little bit higher. So it's definitely a fasting glucose, okay? And so if it's 126 or higher, again, they will repeat that. And they may go to a 12-hour fasting, just to be sure. The other test that can be run is a 2-hour glucose tolerance test. So that's the OGTT, oral glucose tolerance test. This is the same test that they use for moms when they're 20 weeks pregnant. So it's a loading dose of 200 milligrams per deciliter of nothing but straight sugar. It's usually flavored orange. It's a lot like orange syrup, super not cool. Anyway, you drink this right away, and then they will measure your blood glucose after 2 hours. If your body is working correctly and you have insulin available and those kinds of things, it will come down, okay, significantly. However, if it's higher than 200 after those 2 hours, again, they would be looking at probably diabetes. And that one needs also to be repeated. However, so this is the one. A patient with classic symptoms of hyperglycemia, remember our 3 Ps, polyuria, polydipsia, polyphagia, or weight loss, or a patient who has a hyperglycemic crisis, and just a random glucose greater than or equal to 200, there are no repeat tests required. It's kind of then, it's very, very, very unlikely that this patient would just randomly have all this stuff. Yeah, say it here.
For polyphasia, is the S supposed to be a G?
Polyphagia, probably. Could be a typo. Yep. Polyphagia instead of fascia, yeah.
Yeah.
Yep.
So they wouldn't need to have all of those, or?
They would have to have the classic symptoms, all 3, polyuria, polydipsia, and polyphagia, or weight loss. So those, it could be 2 of those and weight loss, okay? Or a hyperglycemic crisis. So that would be someone who actually needs to go to the emergency room. Let's say their glucoses are 700. Again, going to be really unlikely for that to accidentally happen, okay? And a random glucose of greater than 200. So again, they wouldn't have to have, if you're asking the 3 Ps and the rest of them, not necessarily, but the 3 Ps would go together. A hyperglycemic crisis would be separate. Does that make sense? And a random glucose greater than 200. So if your body's working, you shouldn't just have a random glucose of over 200. It could be, like I said, depending on what you've eaten, it could be 120, it could be 130, but not 200. Okay? Any questions on that? Good questions. Okay, so now we're going to start to compare, and this is where I said if you're taking notes by hand, it may not be so that you can write all of this down, but definitely just refer back to this and write kind of some of the major kinds of things. So age at onset. So for type 1, most people develop that before 20. However, it can occur at any age. So, for instance, my aunt got really sick with some kind of virus when she was about 60, and she became a type 1 diabetic. They didn't think she was a type 1 diabetic. They thought she was a type 2 diabetic, so they kept feeding her oral medication and not giving her insulin. She got very, 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 very sick and ended up going from North Dakota to Mayo to simply find out she was a type 1 diabetic, which I thought she had the classic symptoms, which I thought was odd. But it can occur at any age, okay? So don't just discount people who are in their 60s or whatever actually getting type 1 diabetes. Type 2 is usually 35 or older, but it can also occur at any age, especially because of its relationship with obesity. Okay? How are we doing in Rochester? Fabulous? Great. So type of onset, so this would be something you want to keep in your head. Usually type 1 diabetes is very abrupt, okay? You're fine, and then all of a sudden you're not fine. So with type 2 diabetes, again, because of its relationship with obesity, it starts off, you become more insulin resistant, etc., until all of a sudden you basically go to the doctor and have an A1C of 6.5 or usually 7, somewhere in between there, and they go, you've kind of hit that threshold and now you need oral medication, okay? Prevalence, so 5 to 10% of all cases are type 1. So this is an important thing. Most cases, type 2, okay? You doing okay? All is well? Good? 90 to 95% of all cases are type 2. So environmental factors, so it can be caused by viruses or toxins. And type 2, usually obesity and lack of exercise. And what happens with the virus or toxins in type 1 is they think it turns something on in the immune system where it begins to attack itself. So that's kind of the association with the autoimmune part, is that something turns that on and it comes against the insulin. Primary defect, so insulin is absent or there is super minimal insulin production. So there's definitely not enough to sustain life, okay? These people need insulin to live. However, type 2 diabetics are insulin resistant, so they still do have some insulin being produced. It's just not getting into the cells as fast or as easily, and there's often a decreased insulin production. So absent, decreased, okay? And then the islet cell antibodies, so this is that autoimmune piece, often present. And then type 2 is absent, okay? So if I asked you which one of these was caused by an autoimmune reaction, type 1, okay? Okay, so here we are going to continue that comparison. So endogenous insulin, so that's the insulin produced already in your body, absent. Type 2, initially it's increased because of the amount of sugar and food that you're eating, right? But then that's how it becomes resistant, is the body kind of wears out, right? You don't have as much. And so then the secretion also will diminish over time. Nutritional status, usually type 1 diabetics are thin to normal. However, we do have some obese patients, okay? But generally their stature is more thin or normal because they're not getting the glucose into the cells, okay? So it can't get into the fat or adipose cells to store, okay? Type 2, frequently obese, but could be normal as well. Symptoms, again, the 3 Ps are very present in type 1 diabetics who are just diagnosed. Fatigue, weight loss. So this is where we talk about diabetic neuropathy. So that's what that neural problems are and vascular problems. This happens especially out in the periphery, like in the feet particularly, or the fingertips. They'll have numbness or tingling in the beginning. A lot of times with type 2, there really isn't any kind of symptoms, so it's very insidious. However, you may see, depending on the glucose, they might have polyuria, okay? So they might be urinating more, and we'll talk about why when we talk about fluid and electrolytes next week. Fatigue, again, glucose is not getting into the cells. They could have the 3 Ps, and they also can have those vascular or neural problems. Ketosis, which is something that happens when we have very large amounts of sugar in the blood. It can be happen at onset or during insulin deficiency, in a type 1 diabetic, and this is a crisis, okay? We're not going to go into diabetic ketoacidosis. You're going to do that more in your junior year, but just know that ketones generally are not present unless it's at onset or during an insulin deficiency. So if they're being treated and everything is going along great, then usually there are no ketones present, okay? If they're getting into trouble, they're not following sick day rules, that kind of thing, they definitely could go into ketosis. Type 2 resistant except during infection or stress. Again, these are kind of precipitating factors for ketosis. Otherwise, things should be perfectly normal. Nutritional therapy, so how do we treat people and do we need to treat them? Absolutely, it's essential. So for type 1 diabetics, and you'll learn this again in lab, you're going to need to count carbohydrates to figure out how much insulin you need to cover for each unit, okay? And in type 2, it's also essential. You're not going to be counting carbohydrates, but the fewer carbs you eat, the better your body is working with those oral agents that they usually take, okay? And really in the type 2 diabetes, nutritional therapy is really helpful for limiting symptoms like the diabetic neuropathy, vascular problems, eyesight problems, lower limb amputations, and those kinds of things. Patients who don't follow nutritional therapy, in either case, that's those patients. Okay? Insulin is required for type 1. This you have to know. Type 2, most times no, but if you have an A1C of, let's say, 10 when you're diagnosed, many times they will treat you with insulin until it gets down to a lower level, like 8, 7, and then they'll put you on an oral agent. So it's not unheard of for type 2 diabetics to be on an insulin regimen, but basically it's to get them down low enough. They're usually treated with oral agents. Also, our type 2 diabetics, when they're in the hospital because of the strain that being sick takes on the body, then they oftentimes will be receiving insulin in the hospital. We'll talk about why that is. So manifestations, how are we doing? Any questions, thoughts, anything? Do you need time to fill out anything? Moving along, all is well. How about in Rochester? Everything good? Yep, question? Oh, was that just a finger, thumbs up? Super. Okay, manifestations. So hyperglycemia, what does it look like? These patients would have an elevated blood glucose, obviously. But if you did not have a glucometer or any way to check, these are some other things that you might see. An increase in urination, okay, increasing appetite, and that's because there's no glucose getting into the cells. So you feel like you're hungry all the time because it's not getting to the cells, okay? And it can be followed by a lack of appetite as well. So again, that one is kind of wishy-washy. I wouldn't use that one to totally diagnose anything, right? Weakness and fatigue, blurred vision, headache, glucose in the urine, okay? There's a spillover effect that happens in the kidneys. Usually they filter and they keep glucose in the bloodstream because glucose is a larger molecule, but at about 200 grams per deciliter, there is a spillover effect, okay? So that's where you can start to tell that there might be too much glucose in the urine. Nausea and vomiting, abdominal cramps, and again, progression to diabetic ketoacidosis or hyperesmolic syndrome. So hypoglycemia, what do these patients look like? Usually their blood glucose is lower, okay, lower than 70. Now you're not going to see symptoms necessarily relate to 69 or 71. right? So it's wherever your body has been used to being. So someone could feel or look hypoglycemic even though their blood sugar was 75, right? So, you have to be individualized in your care. This is one thing generally that we see only in our hypoglycemic patients, and that's cold, clammy skin, okay? Numbness of fingers, toes, and mouth. They actually start to hyperventilate, and that's what kind of causes that. A rapid heartbeat. So emotional changes, they can get very combative, very confused. Sometimes if you're trying to help them, they don't know why you're trying to help them, who you are. They don't think they need help. It can be kind of awkward, okay? Headache. So again, you can have a headache if you were hyperglycemic as well, so I wouldn't necessarily use that as a diagnostic factor. Faintness and dizziness, generally we see that with our hypoglycemic patients. Unsteady gait and slurred speech, again, that kind of comes from that confusion. Hunger, and you saw that there also could be an increase in appetite with our hyperglycemic patients. Changes in vision, so I wouldn't necessarily say if someone had blurred vision and that was the only symptom that immediately you should jump to any conclusions. Seizures and coma, and hopefully you have come to some conclusion before we get there, because that's a bad place, okay? And there can be permanent damage at that. Okay? So helpful? I would say this is super important, okay? You will need to know this for the next exam, because you might have like a case study question and your patient is presenting with some kind of symptoms and you've got to do something. What are you going to do? And it's going to be based on what you know, okay? So, don't forget that part. Causes. So, hyperglycemia can be caused by illness and infection. Remember, I said a lot of times our patients who go in the hospital, even type 2 diabetics often receive insulin when they're in the hospital. How about this one? Even patients who do not have any kind of diabetes often have to have insulin in the hospital, okay? Because it plays a role in our glucose metabolism, period. Even if you're well, it puts stress on the body and therefore changes glucose metabolism, okay? But if you have patients with diabetes, you need to be particularly careful of any kind of illness or infection, okay? Corticosteroids, so if they take those, I will also say corticosteroids can also cause just normal, everyday people for their glucose to be up and down and all over the place and make you feel relatively crappy, okay? So corticosteroids, too much food, obviously, especially the wrong kinds of food. You probably won't get hyperglycemic from too many salads, but a little too much cake can do it. Too little or no medication. So again, that medication regimen is very, very important. For a type 2 diabetic, generally they will take it once or twice a day. There are some medications that are more than that. But a person with type 1 diabetes generally will have some type of fast-acting insulin with every meal, okay? And then they might have a basal type of insulin that works 24 hours to kind of keep things steady, okay? And so any change in those things can definitely cause hyperglycemia. Inactivity, again, because if you're not burning any kind of calories or whatever, then we have too much glucose, okay? Emotional or physical stress. Stress is a big thing. Remember we talked the last time I was with you guys about how it affects patients with IBD. Anyone who has a chronic disease generally will feel the effects of stress. You guys are feeling the effects of stress in a different way, but our really sick people find it exacerbates symptoms for sure. Poor absorption of insulin also will cause hyperglycemia. Hypoglycemia, what causes that? Alcohol intake without food. Too little food. remember, those fast-acting insulins work within 15 minutes. So if you're giving somebody insulin, or if they're taking their insulin before they actually eat their breakfast, right, and it's delayed for whatever reason, then they're at risk for hypoglycemia. Let's say usually at the hospital breakfast comes at 8, and so you're running around and you're doing all your insulins, and you do it at 1:45. And now all of a sudden, guess what? The breakfast trays don't come at 8. You best be going to check your patients, because that's working. And they don't have any food. So they need crackers, they need orange juice, they need something until their breakfast gets there, okay? So it could be delayed or omitted for whatever reason. Too much diabetic medication, particularly our type 1 diabetics. So if they're used to taking 3 units and they take 5, okay, they could experience hypoglycemia. Now, one of the things that you have to take into is that eyesight is often affected by diabetes. And when you guys get to see those insulin syringes, you're going to see how little a unit of insulin is. And so if they can't see those, that's one of the things that you need to monitor, is that they can actually read those syringes, because it would be very easy to get too much or too little insulin just because their eyesight was going, okay? And that could cause effects, okay? If it's taken at the wrong time, we kind of talked about that. Weight loss without change in medication. So let's say a type 2 diabetic actually starts to work out, they start to lose some body fat, all of a sudden their body is, their cells are not as insulin resistant as they used to be, okay? And they're still taking the same amount of medication, they could become hypoglycemic. So it could be just a difference. Use of beta-adrenergic blockers, which can interfere with recognition of symptoms. So a lot of times beta blockers can mimic those same symptoms. So a lot of things for the nurse to monitor. So treatment, what are we going to do for these folks? So if we have hyperglycemic patients, we're going to seek out medical care if the glucose is high enough that we're seeing symptoms that are bothersome that they can't take care of at home, okay? If they have forgotten, like their metformin, which is a common medication for a type 2 diabetic, they need to continue those as ordered. Check blood glucose frequently and check urine for ketones. Remember, if they start to develop ketones, this is a crisis, okay? Not like right when they start to develop ketones, but it means their body is starting to use protein and other things for glucose, and they probably need to check in with their physician or go to the hospital, okay? Drink fluids, lots of fluids, and we're going to talk about more about why that is when we talk about fluid and electrolytes next week. But suffice it to say, it's a concentration issue. We're trying to dilute the blood system with more fluids so that it's not so concentrated with glucose, okay? Contact the healthcare provider regarding any ketones in the urine. So there's not, like I said, the hyperglycemic folks, you know, they're not like so critical. If their glucose went up, there's some things that they can do, and it's not like an immediate, we've got to get on this. Hypoglycemia, on the other hand, I mean, people can die very quickly, okay? So you're going to follow the rule of 15 for a conscious patient, which is you're going to have the patient eat or drink 15 grams of quick-acting carbohydrates. There are little pills that a lot of diabetics carry, and they look kind of like a roll of Rolaids or something like that. And each one of them are 15 grams, okay? And so there's also a gel that they can squirt in their mouth. There's different ways that they can get those carbohydrates. If you don't have any of those pre-measured things, we want to be thinking about a 4 to 6 ounce regular soda. This is not the time for the diet sodas. 8 to 10 Lifesavers, a tablespoon of honey, some jelly. We want this sugar to be readily available. Orange juice is another really good one. Now, after these folks get that 15 grams of quick-acting carbohydrates, if they come out of this, they need some real food with protein and some different things quickly, because what this is going to do is raise our glucose like this, whoosh, and there's nothing to keep it up here, whoosh, come right back down, okay? So this is not a fix-all, all right? Wait 15 minutes and check the glucose again, okay? And also monitor symptoms if they're not feeling any better. Yep, Ashley.
I just have a question about the 8 to 10 lifesavers, because I feel like that's not a very quick method of
Actually, if they can chew them, you can chew them and get them. You know, how many lifesavers does it take? The owl? No, I'm just kidding. Those are Tootsie Rolls. But anyway, what it is it's candy.
Yeah, but
so if you think about what that looks like, if someone had 3 butterscotch candies, what you don't want to do is give them a mouthful of junk, right? And then their glucose shoots up, and we have absolutely no idea how to cover that. We don't want them going up so high that we're like, okay, now we give them 2 units of insulin. Okay, that didn't work. We're going to give them another. We got to get it back down. So we don't want them to have like a bag full of Halloween candy. Does that make sense? Is that helpful?
Yeah.
So start little, and you can see if it doesn't work, you're going to give a little bit more, and then you're going to call for help. Good question, though. Yeah. And so basically, it's just kind of a, yeah. Hopefully you're not having to count lifesavers. But if someone had candy, you certainly could use that. Now remember, this is the conscious patient. Never, ever, 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 ever stick anything in anybody's mouth that's unconscious, okay, ever. So like I said, you're going to wait 15 minutes, and if the blood glucose is still less than 70, you can have the patient repeat the treatment, or you can help them repeat the treatment. And this is exactly what the EMTs will come and do. So if you have a patient who faints for no reason, they're going to do an automatic blood sugar. If that blood sugar is low and the patient comes to, they'll treat them with 15 grams. They'll wait 15 minutes, treat them again. A lot of times they don't spur them off with lights and sirens right away. Okay. Once the glucose level is stable, then the next meal, if it's more than an hour away, you want to give the patient some additional longer acting foods like protein, fat. So crackers isn't like a huge one, but you can put peanut butter on it, okay? Or cream cheese or string cheese or something that's got a little protein that'll help it stay up a little bit, okay? Again, immediately notify the healthcare provider or emergency services if the symptoms don't subside after 2 or 3 administrations. And that's why it said the medical alert band on that one where you got to choose all questions were correct, because it does help provide information to healthcare people, which can help prevent hypoglycemia by making sure people get things to eat, okay, if it's not like a nurse or whatever. If the patient does worsen or become unconscious, you can use subcutaneous or IM injections of glucagon. Glucagon is like syrup, basically, and you basically administer it to the thigh or somewhere. This isn't the time you take off someone's britches and you use alcohol in a nice, circular motion. This is poke and jab, just like you would epinephrine if someone were having an allergic reaction, okay? Most diabetics who are type 1 diabetics carry both, so they have access to both. And you can also administer 25 to 50 mils of 50% glucose. That would be in a hospital kind of setting. Yeah, Xavier.
Where is the best safety for fast acting?
But I just go straight for the thigh. Just, yeah, absolutely. It's nice, big. You don't have to, you don't have to secure it like you would in the arm. You can just jab it without worrying like it's going to slide off or whatever. Yeah, Isabel.
Is the hormone that increases that?
It's glucose. It's just glucose. Okay. Yep. Are we doing good? All right. This might be a good time to take a break. Why don't we take 10 and we'll come back. I want to give you guys plenty of time to work on that case study, so during the case study, if you need to get up or go to the restroom or whatever you can. I'll see you in Rochester in about 10.
I was.
11th then, so all it was
Can't remember name. That's about.
I don't know.
I'm not congratulating myself.
Maybe sad. It'll be like, okay, give us this many, and then I'm like, wait, you know?
I just want to go home and cuddle. The icing on be connected.
Wait, when you
That's my name? I gotta watch that. I gotta read for it. 30 minutes. I put it on 1.25. My dad has balls. 1.5. What's the way better with this?
Oh, I always pause it.
Yeah, I would go.
I feel like something
Addicted though.
honestly,
Yes, another idea.
oh, now they have this.
Yeah.
I'm at 40.
Yeah. I just maybe so tired of
He's dropping.
and so then I just go for
It's like I'm eating Asian lifestyles indulgently by myself.
Oh, my dad.
Like this? I know, I'm like,
this is terrible.
I don't know. Either way, we'll probably do it.
And so I'm like, I'm eating
that role play too. Yeah. So, I might stay in with the students. I'll take either one in the hyper direction. And only kind of verse the nurse. I had other ones. It says right on there.
and I thought Shannon,
My jacket. We're like always laugh.
and they sent me home.
I'm not sure. 2 seconds. I'm not sure if
Really? Take cookies. Oh my god, you guys are trying to kill me. Because they sent me home
I'll take them out. These are what
like lunch, like
Okay. This is what you're going to give to the nurses. So they need to be tracked what the positive symptoms are. Okay. For that, they need to provide okay. 4Ms are medication monitoring. I'll have an actor and a narrator with these.
that's the one.
Two people out of each group. Okay. Just the 6 officers.
I don't know. It wasn't.
4 will be here, and they will need to be the nurses. So I would say that's how they're told. They asked them. They're not super useful. I mean, you might have
And the only that's crazy.
anyway, so, but I did put them in here so that they could ask.
So 2 minutes.
Two students from this group, patient, they will be there, and the narrator. Okay, so the patient is like doing whatever, narrator questions.
It's a good beat.
They will not give them any information.
I know what
How to spit. That's how they're going to get them. So that's how it is. They're going to ask lots of questions.
But I think that it was just it's more
in your junior year. We just talk about that. That's what
yeah. That sounds great. And then I'm gonna want to find between them. I just want to have the wall right there.
We're going to hand these out to all the students. And it's really nice how long they ask questions about and I want you to talk about beforehand. Social. Especially, I
want the whole transcript. I do.
And if you don't do that, you don't get that information. Anyway, and then, so the other thing, this is all, I would say, on these sheets classes, but all the time so I can leave these so that you know you can go to all you have, so that you don't have, that's all you have, you don't have a computer.
Okay, I'll just one. I know. I'll do two. Wait, yeah. I'm really wait, it's not big on top of you and Ellie.
And you could express
I wish you could. I know you have like
Oh yeah.
like education, but also like undergrad degree. There's a lot of
way rather
basically are
coffee.
I know that's responsible policy of education, but like patients nurses that have less education usually watching don't have as much knowledge or information. Over here at right now. Anyway, she's I got it. I was going to say, in your junior year,
Names that go out together. We haven't done diabetes like at the end of the year.
Oh, okay, well then you might see her.
No, actually, for 2 weeks. Part of that lecture. Our friends. We all lived on the same block. And then like, oh, I don't know. We moved in.
But like we're not. You can be like.
Like it would work, but then like kind of look at things like the aisle and those are my page. I did that for a reason. That's good. That's sorry. So it was like I literally just bought
Hello, how are you? Things going good? There you go. It's kind of a long answering questions that might be like might have and then I go
way out. And then we're just about to I don't know. When I got
okay, everybody back? Would somebody just pull that door shut? Back there? Austin, you want to?
What was that? Oh, yeah.
Oh, great, thanks. You know those people in the lab, there's a voice. Hello, Rochester, everybody back? All good? All right. So let's continue down the journey of diabetes and see how we're doing. Okay, so what can we do to prevent hyperglycemia and hypoglycemia? Because really, as a nurse, our life is really about prevention, okay? So to prevent hyperglycemia, again, take prescribed dose of medication at the proper time. Like, seriously, we need to educate our patients about the damage it does to our body. When glucose levels are too high, it destroys the circulation, and that's where they end up starting to get the problems of ulcers, diabetic neuropathy, retinopathy in the eyes, etc. It's from the little tiny veins that are running throughout the body, and glucose actually destroys those. And so if they can keep their blood sugars as close to normal as possible, then they have a less chance of having major problems, okay? And again, administer insulin, non-insulin, and injectables accurately. And that really is talking about not taking too many oral agents or not getting too much or too little insulin. Both of those are a problem, okay? Maintaining diet, this is probably one of the hardest things, but really it's a healthy lifestyle. You know, it isn't like you can never have anything sweet again or those kinds of things. You just have to plan coverage for it. So if you're going to a kid's birthday party or you're going out with friends or whatever, then you count those carbs and you cover those carbs, okay? Adhere to sick day rules when ill, and we'll talk more about what sick day rules are. But adherence to those can be really difficult when you've got the flu or you're feeling really lousy, but it's super important. Check blood glucose as ordered. So if your blood sugar should be tested 4 times a day, one for each meal, and at bedtime, then you really need to be able to do that. To make sure that you're administering the right amount of medication, you're not administering it when your blood sugar isn't high enough, that you get the coverage that you need before bed, all of those kinds of things. So it's very, very important to be monitoring glucose levels as well as getting the medication that you need. And again, wearing diabetic identification. I would also add one more on here, and that has to do with not just maintaining diet, but hydration. So when you get really, really dehydrated, it's not like you're eating more carbs, but your veins are much more concentrated, the plasma, and so glucose levels will be higher just simply because of the concentration levels. So hydration is a really big deal. So if you think about our older people who are more prone to dehydration, and perhaps they have either type 1 or type 2 diabetes, it's now like double essential that they get the amount of fluids that they need. Hypoglycemia, again, taking the prescribed dose of medication at the proper time. I can see that you guys should be able to start seeing like a real tight loop of what's going on. Adequately administer, ingest all recommended foods at the proper time. So in other words, some people will take their insulin after they eat, so that's carb counting. You actually count the number of carbs that you eat them, and then take the insulin that corresponds to the exact number of carbs that you ate, okay? Other people will do a set amount of insulin before each meal. Now, that only works if you're really doing what you say you're going to do, right? Because if you're adding on that extra piece of cake, or if you're not eating your baked potato, right? Because we can cover that. But if you say you're going to eat one, and then you're not, then you're going to start getting hypoglycemia, because you're still going to be getting the same amount of insulin, but your blood sugar is going to fall low. So it's super important to ingest all the recommended foods at the proper time, okay? And that will have to do with whether you're taking a fast-acting insulin, intermediate kind of insulin, or like the Levemirs, those kinds of things, really. That's just a basal level. Be able to recognize and know the symptoms and treat them immediately. Remember, hypoglycemia is the most dangerous, okay? So you have to be able to recognize that immediately. All patients who are diabetics, particularly our type 1 diabetics, need to be carrying simple carbohydrates in some form, okay? They should also have access to or carry with them glucagon, okay? Educate the family and caregiver about symptoms and treatment. So, for instance, I took students to Peru with me twice, and I did have a diabetic student that came with us. And so we had one day that we were preparing to go to Peru where we talked about nothing but what would happen with her diabetes. So, you know, if we noticed that she was getting hypoglycemic and she didn't notice, you know, where did she keep her fast-acting glucose? She had glucagon, so I trained everybody to use her glucagon. You know, we had to make sure that because we were going into an area that's like 20,000, you know, miles above sea level, not miles, feet. So, you know, it changes everything, and you can definitely experience more symptoms at that level, particularly if it's that many miles, you know, and up at the moon. But anyway, if you have a new caregiver, or let's say it's a boyfriend, or you're in a sorority and you are diabetic, it's good for people that you're becoming close with that they know what's going on. Check blood glucose again as ordered, and wear a medical alert identification. I will tell you one of the dangers of monitoring blood glucose is that those little strips are like super expensive. Those little tiny strips can be over $100 a bottle, okay? So it's not the machine, which costs $39.99 at your local CVS. You have to have a doctor's script to get the vials that have the strips in them. And so what we do see is that not only do patients ration their insulin if they have financial problems, they also start to ration their monitoring supplies, okay? And so sometimes there's not a lot they can do about that. And really, when you think about it, if you were going to have to pick whether you buy insulin or whether you buy chesting strips and you can't buy both, you're going to buy the one that's the most life-sustaining, right? And so we have to be cognizant of people who are having financial difficulties. Ask those really hard questions. Be understanding. Sometimes there's resources where we can get them some of those at a lower or reduced cost. But sometimes we just need to be sensitive to the fact that we may have to do more training about symptoms so that they start to recognize symptoms, or meal planning, or those kinds of things, because they're not going to be monitoring. But those are questions you need to ask. Don't assume just because they have a script for monitoring supplies that they're actually using them, okay? All right, moving on. So we're not going to get into depth about pharmacology, okay, about different kinds of insulin. But I do want you to see what's happening here. So aspart is a very, very fast-acting insulin. And there you can see its peak is at about 15 minutes. So this is why I say you need to be careful when you're administering insulins to know what kind you're administering so that you know what kind of window you have for how quickly they need to eat, okay? And maybe if your patient has aspart, the reality is you can give it even immediately after they eat, which is safer. If you had to pick, it's safer than chancing their meal not coming, okay? Generally, we try to administer it as close to their meal as possible, but obviously a nurse can't be in 100 places at one time. So if you're concerned, okay, the insulin's going to work the same whether you give it right before or right after, okay? But you wouldn't want to chance it. Now, if you have regular insulin, that's about a 2-hour, okay, peak. You've got plenty of time. NPH is a more intermediate acting. You have lots of time in there. Detamir and particularly glargine, you can see that's a basal level, and so is detamir. It usually covers about 20 to 24 hours, and it just keeps that glucose level, right, not the glucose level, but the insulin level at kind of you're getting some all the time, okay? Now, patients also might be on pumps or different kinds of things, so you need to ask, okay? And they may have several different things going on at one time. Most patients don't just do aspart, okay? There is something else that they use for in between, okay? But just to show you how important it is for you to know what it is you're giving or that a patient is taking, particularly that you're caring for. So implementation of care. So here's some health promotion. This is where we're going to get into some exercise and some sick care kinds of things. So again, teach risk factors and encourage lifestyle changes, and they can be small, right? Even if, let's say a type 2 diabetic is encouraged to just lose 10% of their body weight, a lot of times they can drop down the amount of medication, or if it's not terribly elevated, they might be able to get off their oral medication altogether, okay? It isn't that you want to do things fast, like fad diets or anything like that, but lifestyle changes, so that you're really thinking more about meal planning, about monitoring your glucose, medication adherence, and those kinds of things, okay? Encourage screening. So I'm not really sure in your public health how involved you are in screening. In North Dakota, we would, our nurses would go to the powwow every year, and we would screen at the powwow, and you saw one of the places where diabetes is prevalent, not that, white people can't have it too, but one of the places where it's underdiagnosed and underrecognized is in that Native American population. And so we would go do screening at the powwow, and almost every year we'd have probably 4 or 5 referrals. And so it's important to encourage everyone to get screened at some point or another, but particularly if they're experiencing any kind of those symptoms that we talked about. So self-care and management of disease, so sick care, this is where it gets kind of difficult. So if there's an acute illness, like let's say the flu, since this is flu season, but also for injury and surgery, blood glucoses tend to increase. Now remember I told you that cortisol, one of those kinds of things, our body actually makes cortisol as well. And it's released when we are under stress, okay? It's also released when we have infections or when we have illnesses. So part of what happens is that when we're sick, we're in a hypermetabolic state. In other words, it doesn't seem like it when you're laying around on the sofa, but our body is actually working overtime, okay? So it's using a lot more ATP and those kinds of things. What are you doing? You're eating less and you're drinking less, right? Your body is still working, okay? So you have to, and particularly patients with diabetes, they need to keep taking their medications, okay? It's very difficult for them when they don't feel well, okay? So checking blood glucoses every 4 hours. Type 1, if the blood glucose is greater than 240, should definitely start to check those urine ketones. Remember that number about 200? Okay, we used it when we were looking at diagnostic criteria. If you kind of think about that number, that's kind of where ketones can start. And remember, ketones just starts to equal what we're getting close to a medical emergency, okay? So that would be when we would want to seek help from a provider, all right? If the blood glucose is greater than 300 twice in a row, or there are urine ketones that are moderate or higher, the physician needs to be notified, okay? So, type 1 diabetics with a blood glucose of greater than 300 may actually need to increase their insulin. Okay, they're eating less, they're moving less, but they still need to increase their insulin, okay? Remember, sickness is a hypermetabolic state. We need to cover for that breakdown of glucose in the body. It's coming from the liver, it's coming from adipose tissue, it's not necessarily coming from chow, right? Because, I mean, chicken soup, how much can that be? And you're probably not even having very much of that, right? But your body itself is breaking down and creating glucose. Type 2 diabetics may need to initiate insulin treatment, and we will see this sometimes when we have patients in the hospital. You'll be looking at their chart and you're like, why is this type 2 diabetic on insulin? Or even more interesting is a person who doesn't have either kind of diabetes also needing insulin, okay? Because it doesn't matter whether you're diabetic or not, sickness is a hypermetabolic state, okay? So diabetics who are ill should continue to eat during times of stress and illness, if at all possible. So finding anything they can eat, okay? But even if they're not eating much at all, they need to increase fluids. They should continue to take their medications and insulin and supplement with carbohydrate-containing liquids, okay? So when diabetics are sick or have infections, it's more dangerous for them. They definitely, we're not so worried about them getting as hyperglycemic, but we're super concerned that they'll get hypoglycemic, okay? And then if they absolutely can't keep anything down, no fluids, no food, no nothing, probably would contact a provider. Depending on their age and other comorbidities, this patient might actually be admitted to the hospital for IV fluids and those kinds of things. Any questions on sick care? That'll be something that will be very good for you to know for the next exam. During surgical procedures, blood glucose will be managed. So, like I said, if you actually are having a surgical procedure, oftentimes you're getting insulin and don't even know it, okay? Very important to treat unconscious diabetic patients very carefully. Just remember that no matter what. So really what our goal of diabetes management is to decrease the symptoms. We decrease the symptoms because that it can cause those acute complications later on. We want to promote well-being, right? And so we don't want our diabetic patients to feel like they're less than or can have less than, or it's like a life sentence, those kinds of things. Really properly managed diabetes, these patients live well into their 80s and 90s, okay? But it's how well things are managed. We want to prevent those acute complications in the eyes, the kidneys. We don't want them going on end-stage kidney disease patients end up going on dialysis or lower leg amputation. We want to delay onset and progression of long-term complications. Other kinds of things we're going to do, if we think about the slide before that, is like proper foot care, right? Shoe fittings, those kinds of things. Nutritional therapy. So we think about carbohydrates as the thing really most diabetics need to manage. We really want to have a minimum of 130 grams a day. Like I said, some days are going to be different. Diabetic educators are nurses that are trained specifically to manage diabetes. They often know, I mean, I hate to say this, but they often know way more than doctors do about that specific disease and that specific patient, okay? So not just the disease where it would be book knowledge, but how that patient is actually functioning and what we need to do to keep that patient well, okay? So diabetic educators, if you ever need to reach out for referral or resources, they are an absolute wonderful resource. They know so much about how to help these patients, okay? Carbohydrates, they do come from, and some should come from, all different kinds of things. So, you know, cake would be our least favorite. Fruits, vegetables, grains, beans, and low-fat dairy are all really good. We've already talked about how important it is to monitor. You can substitute some artificial sweeteners. However, the recommendation is that that's as minimal as possible, okay? So that you don't eat like candy bars that are, you know, no glucose and they have all these artificial sweeteners, or that you drink a 12-pack of soda because it's diet and those kinds of things. Because there's other things, some of those artificial sweeteners can cause damage in and of themselves at large doses. Fiber is a really good thing, and what it does is it slows the metabolism of carbohydrates. So keeping that fiber up is awesome. Should be a minimum of 25 to 30 grams. Woo! I fell off my shoes, all good. And again, we already talked about artificial sweeteners. Protein, 15 to 20% of total calories. Now, high protein diets are not recommended for diabetic patients because of the damage it causes on the kidneys, okay? So this keto diet that is so fabulous right now, if you have a type 2 diabetic who wants to lose weight, this is not the diet for them, okay? And you need to be able to explain why not, because their friend who did that diet lost 25 pounds in 20 days and they're feeling fabulous, lots of energy and all that, but they don't have diabetes, okay? And you only get 2 kidneys, right? And if you start to damage them at the rate that you can when you start doing things on purpose that can damage them, you want to save that for much later, okay? So just remember, high protein diets are not recommended for our diabetic patients. Fat, saturated fat, less than 7% of total calories. Again, so like the Mayo diet, right, where you can eat, eggs and everything that has so much fat in it like crazy. And that's because you're not eating carbohydrates. So what's happening is your body is burning nothing but fat. It's the same premises as a high protein diet, only it's a very high fat diet. Not good for our diabetics. They really need to think about moderate and staying kind of steady Eddie. Trans fats should also be minimized. Cholesterol less than 200 milligrams a day. And like I said, your diabetic educator or a registered dietitian can definitely help them with the foods that they like to eat and finding a way to work those into their diet, but so that it's balanced and so that it will keep them healthy. Okay? Alcohol, we really want to think about moderation, just like it was with the foods. 1 drink a day for women and 2 drinks a day for men. You cannot bank them. In other words, you can't save all 7 for Friday or Saturday night. They have to be kind of 1 a day, or you just still get 1 a day on Saturday. That's also one of the guidelines for cancer prevention now, is the same thing. Alcohol should also be consumed with food so that there's less spikes in their blood sugar. And remember, mixed drinks, particularly ones that are mixed with orange juice or triple sec or some of the other additional kinds of things besides the alcohol, can definitely raise blood sugar. It's very important for your patients who are young for them to have this kind of knowledge. Don't assume just because someone is 14, 15, or 16 that they're not drinking because the age is 21. We had a patient in North Dakota that would come into the ICU all the time, 700, and she was 16, and she would just go out and binge drink until one of her friends would drop her off in the ER. It was very tough. And then it kind of became a pattern. We saw her much too often. So it's good right away when they're diagnosed, no matter how young they are, that you start to build that good habit in there and explain to them why. This is less about not drinking until you're 21 because that's the law. It's because of your body and what can happen to your body, okay? Exercise, so we do want people to exercise, however, they have to exercise caution. So regular, consistent exercise is essential. What the recommendations are, I think in this last ADA, is about 150 minutes per week. So 30 minutes a day for 5 days. The biggest thing is, and if someone exercises more than that, that's great. But they just need, everything about diabetes is about consistency. Because remember, their medications are based upon consistency, okay? So moderate intensity aerobic activities, if someone is diagnosed early and is still, really healthy and those kinds of things, that's great. If we have our older adults, we still want them to be able to exercise. It may not be moderate intensity aerobic activities, but we still want them to move, okay? It does decrease insulin resistance, so it makes the cells themselves more easily taking up glucose. Reduces triglycerides and other kinds of fat, which can help with stroke and heart disease. Remember, diabetes is a really big risk factor for stroke and heart disease. Any new programs for exercise definitely should be cleared by their physician. And, they should really talk about what that consistency looks like. They usually will monitor blood glucoses very carefully before and after exercise so that they can make sure that they're getting the proper amount of insulin and carbohydrates. Hypoglycemia is the biggest risk to people who exercise a lot. Not, probably not a big surprise. So we usually have them start slow and use caution when exercising during peak times of the medication. So a lot of times we'll say, you want to do it on the tail end or whatever, instead of like that peak at 2 hours or 4 hours, depending on what kind of insulin they're using, okay? Definitely eat before and after exercise. Make sure they're carrying fast-acting carbohydrates. Check blood sugars before and after. And honestly, if their blood sugar is really elevated before they even start, like let's say 250 before, really they probably shouldn't even do it that day. It can, again, you don't want to get into a hypermetabolic state where everything's burning, right? And make sure that they have that fast-acting glucose available. Glucose monitoring, it does help patients make good decisions regarding food intake, right? Activity patterns and medication dosages. You just need to be sensitive to the fact that they're very expensive, okay? It helps them maintain blood glucose levels and avoid hypo and hyperglycemia. And when we do that, right, we avoid those long-term complications. Kind of the frequency, again, will depend on ability and finances, which we've already talked about. The goals. If this is a young person, 16, and they've just been diagnosed, there's no reason they can't live till 94 and not experience any of those long-term complications. If their goal is to live a long, healthy life, then we need to have them monitoring more closely so that the medication can be tighter, right? With our older adults, we don't want them being super tight with their A1Cs or those kinds of things because they get hypoglycemic much quicker, okay? We can't be quite as tight on them because we risk hypoglycemia. But for folks your age and who are healthy, it's really what your goal is, okay? It's the decisions you make and your patient makes that really determine those kinds of things. The type of diabetes, obviously, if you're a type 2 diabetic, you don't need to test 4 times a day, okay? Type 1 diabetics are usually the ones that are testing 4 times a day. Medication regimens. Hygiene, so we need to be absolutely sure that we make sure patients understand that they are at risk for infection and those kinds of things because their blood glucoses are a lot of times higher than they should be. What do bugs love? Warm places and glucose, right? That's what they live on, right? So if you have someone who's not doing very good perineal care, right, and their urine has glucose in it, then bacteria are going to grow there. I mean, the perineal area, remember, is very close to the rectum, so we have E. coli right there, right? So they're going to get urinary tract infections much more easily than someone without diabetes. Also, you need to let dentists know because they're going to be more careful to not break the skin in the mouth. And they are more at risk for periodontal disease just because of that high glucose level. Okay? So regular bathing and keeping things clean is absolutely hugely important. There's a huge emphasis on foot care. Remember I said that's the largest group of people who have lower limb amputations. What happens is, especially if they've not really kept a good eye on their glucoses over time, and they do have severe peripheral neuropathy, it goes beyond what you guys did in aging, where you just simply kind of can't feel. These people can't feel anything. I mean, we have had patients who have stage 4 ulcers. That means all the way to the bone. And you could stick something horrible in there and go like this, and they would never feel it. Okay? And so the reality is, if they step on a rock with bare feet or stocking feet, the reality is they could be losing a leg. I tell this story. We were at the VA with students, and there was a gentleman who was actually going in for a lower leg amputation. He had been in about 3 weeks earlier, and he had twisted his ankle. And so they put him in one of those boots, the boots to keep his ankle straight. And whoever it was, I don't know if it was a nurse or a physician or who it was, but they didn't fit it properly. And so every time he walked, it rubbed on his ankle, okay? And he never felt it because he didn't feel anything on his feet. And so finally, he looks down and it was on the bottom side of his ankle, and he had this wound about this big. When he finally got into the hospital, there really wasn't anything else they could do. They did try a wound vac. They tried a lot of different things to care for it. and it was just too far gone. And so he ended up losing his leg, okay? So it can go from 0 to 50 in a very short amount of time. And so even if, I'm saying, even if you work emergency room and you're fitting different things on people, remember how careful you need to be with diabetics, okay? Anybody else would have been like, this doesn't fit right. And they either would have come back in or they would have moved their foot around in there and made it so that it was comfortable, right? But if you can't feel anything, you don't know. And that's how they lose their feet. So having them actually inspect the bottom of their feet, like with a mirror, either that's placed on the floor where they can look, or they make mirrors that are on like a long pole with it kind of bent like this, like a dentist tool, only bigger, so that they can constantly monitor their feet, that their feet get dry, okay, between the toes, where a lot of times we don't dry, we just expect it to dry. They need to make sure that that's dry so it doesn't macerate and become a wound. They really don't feel anything. My students did dressing changes on that guy before his amputation. He didn't require any medication, and what they were doing was absolutely awful. Nothing. He couldn't feel it at all. So just so that you know, foot care, hugely important, partly because you step on things and you know, like I said, if you did, you'd be like, oh, that hurts, and you'd look, they can't. And you don't see it as often as like your hand or other areas. Same way with shoes. Diabetic shoes need to be fit properly so that they don't rub on their feet and cause the same issue. Education, again, going to match the goal. What's the goal? Okay? Self-management. If they are in active participation and able to tell you what their goals are and be able to stick within those guidelines, they're going to have way better outcomes. And remember that education is empowerment, right? And, you know, for any of you who have any kind of disease or whatever, you know, if you're given the information, you know what to stay away from or what to do to make yourselves better. And if you stay within those guidelines, you have better outcomes. And when you step outside of them, you know, stuff goes to heck. Barriers, what are the barriers? And obviously feelings of inadequacy about one's ability can become a barrier. So really talking to someone about how they feel about managing their lives, you know, perhaps they're not very good at it, and that can be a barrier. How can we help them, right? It's not guilt and shame. We really want to empower them. Now, there are people who are unwilling to make changes, and all we can do is educate, support them when they come in, try to provide very non-judgmental care, but know that they're out there. I mean, they know what they're doing, and they choose to do it anyway. It's just like any other kind of disease where people don't make the right kinds of choices. Ineffective coping skills, so that kind of goes along again with they're not able without help to do the things they need to do to get to the goals they think they want to do. So maybe you need a referral to mental health or those kinds of things. So having a good dialogue with these patients is very, very important. And sometimes there's cognitive deficits, okay? So particularly for our older people, if you're dealing with someone with cognitive deficits, may have to be dealing with caregivers. And, you know, like my husband's mom was this little old German lady who made cookies every holiday, and not just like one tray of cookies, we're talking like 22 trays of cookies. And she liked for everybody to eat, and how they cooked was very carbohydrate heavy. And they can almost feel like it's, family can feel like they're upset, or I don't know how to put it, but that you're not eating all their food kinds of things. So you really need to explore what those barriers are. Again, chronic complications, for those of you who looked at the PowerPoint study guide, you got to see some of those pictures. But high glucose concentrations damage those blood vessels, and that's what the angiopathy means. And particularly very small vessels, coronary vascular disease, Primary cause of diabetes-related death is heart disease and stroke. And tight glucose control can really slow or actually prevent some of that damage. Ta-da! Da-da, da-da. Any questions? How about Rochester? So I think what we're going to do first, if there's no questions, is we'll do the role play, and then we will move into the case study. So what I want for you guys to pay attention, because this can get kind of confusing. In your groups, I want you to choose 2 people. One person is going to be the patient. One person will be the narrator. And they are going to join Lindsay outside the room or myself here outside the room, and you'll receive directions. The rest of your group will stay in the classroom, and you will get a piece of paper that you can jot down notes on. You're going to actually be completing an assessment of the patient, okay? And then you're going to try to figure out what's going on, what do these symptoms mean. And then you're going to develop a care plan and some education for your patient, okay? Any questions on that? So what I'd like for you to do right now is pick those 2 people who will join either Lindsay outside the room or myself. And we will go ahead and start.
Alright. I'm gonna call this one, guys.
Okay, do I have all the patients and narrators?
This is like this thing last time I was like by next Thursday. This one
Save the day.
like review style. I don't know what it's going to be. Really the source. Nice. I think I'm just gonna use the thing that they have like thing on. To be honest, I don't have 4 M's on 4 twice. So what are we going to put on? It's your job 4. You guys. You want to argue first? 4 M's. I don't know what that is. I don't know what the 4 M's. Okay. Okay, well that could be like a symptom that we would like to work. Okay.
Alright, so everybody got a sheet in here that says, give this to the nurses, yes?
Yeah.
Okay, so like Dawn said, it's your job to determine your patient will come in with a narrator. And they're gonna be expressing some symptoms, and it's your job to determine the cause of those symptoms. What you have, you might want to write this down, hold on. I can find the piece of paper that you need. Alright, you have a stethoscope, a blood pressure cuff, a thermometer, assorted dressings, a pen light, and gloves. Rochester, I don't know if you guys are doing this separately. Can you hear me even?
Yeah.
Yeah? Okay, did you all get the worksheet?
No.
Does anyone have a worksheet there?
They don't have a teacher.
No.
They don't have a teacher though.
It literally just says, you can just read it.
Okay, well, the sheet says, did you have people who left the room?
Yeah.
Okay, so the sheet says that you're a nurse and your patient's gonna come back and you have to determine the cause of their symptoms, okay? And then when you determine the cause of their symptoms, you need to provide them with education and treatment. Did someone write that down, maybe? And then for education, you want to give them the 4 M's that Dawn talked about. 4 M's? 4 M's? They were in your reading, I believe.
I did the reading.
So it's meals, monitoring, medication, and I'm going off memory here. I don't remember the 4th one. I can look it up though. Meals, monitoring, medication, and mobility. Yes, it's mobility. Okay, meals, monitoring, medication, and mobility.
I think you finished that about.
Yes, we're educating. So you don't know their diagnosis.
And to get like. Oh wait, but we know they have diabetes. No, I don't think we know that.
What's diabetes?
Well, we don't know that, but now we.
I would say you can infer they do.
Diabetes.
But we don't know.
But it's not diagnosed yet.
Yeah, it's not diagnosed, it's just symptoms.
What is mobility? Julie, do you want to be a professor? Oh, exercise.
Yeah. You do? Okay, so did everyone get what you have in your bag? A stethoscope, blood pressure cuff, thermometer, dressings, pen light, and gloves. You cannot get a glucose value. Your narrator will act as like a person of reference to ask about your patient's symptoms. Any questions?
Okay, well, we can ask about their.
Cool.
Yeah. I was wondering if you like sample like oh yeah, I've been tutoring people since I was.
My high school had really good math program, so that's why I decided nursing. I thought I wanted to do math.
Is that what that is?
And then.
Just considering like this is all the last diabetes, yeah.
I had so what it says
Also, could you?
Okay, guys. The biggest thing here is, hopefully Juliana told you, so you are the home care nurse, Jessie, right? You're coming to do a visit.
I don't feel good.
Did you read that first?
Yeah, there was no name Jessie on there.
Okay.
Oh, there is a name.
Yep.
Your name's Jessie.
Your name's Jessie. All 4 of you are Jessie, because there's a girl name and a boy name.
Oh, yeah, I didn't see that top part either. It is a type 1 diagnosed diabetic.
Oh, okay.
Yeah,
That's good to know.
Okay. And anything else?
No, I gave them the 4
Okay.
M's. Good. And there's a patient.
What up?
We're already have type 1 right now.
You're going to you have to, but they have to do a treatment.
Yeah, this has.
So, figure out what they have, do a treatment plan, and then some education. I'm going to check in with Rochester before we get going. So, shh. Lindsay, are you ready to go? Oops, I couldn't hear you. You'll have to, okay. Shh, please, guys. What now?
Are we gonna get started?
Yeah, I'm ready to get started. Do you have any questions, or are you ready to get started? Okay. Ready? All right, we're ready too. Okay, I'm gonna go get it. Be kind, be gentle.
Emotional dizziness. I feel like they're gonna be numbness. They have some. Oh, because it's more intense. I know. Yeah.
Oh, wait, I can see myself.
Always got an unsteady gait, I think.
It's called.
Clammy skin. What is that? 101. Oh, we got a tachycardia. They're trying to go.
Are you cold again?
I can't tell if that's
Okay. No, no.
so cold and so I know actually.
You know, I'm not dizzy. He has type 1 license. Alright, we gotta get rid of you guys and him. So we gotta get your mom.
How's it going in Rochester? Any questions? So remember, there's other reasons you can be hypoglycemic other than it having to do with insulin. So if you forgot to take your insulin, what other reasons could there be that you would be hypoglycemic? Because it really doesn't have anything to do with your insulin. So remember when we talked about things like being sick, think about when we talked about exercise, when we talked about not eating the right amount of carbohydrates. So remember, there's other things that can play into it, even if you're taking your insulin the right time. But think about if your patient is still experiencing hypoglycemia and it's not about insulin, why else could it be? Okay? So dig in there a little deeper, and I'll let you guys do some more planning of care, and education is probably the biggest piece I want you to do. And we'll come back together in about 3 minutes, 4 minutes, okay? Okay, so I hope that you had fun. Kind of the biggest thing I wanted to be for a takeaway here is about education and about kind of individualizing those kinds of things. Thinking about, although you're a nurse and you're not going to prescribe medication, what is it that your patient needs to know? Take it when you're supposed to, right? Take the amount you're supposed to. If you do something different, like not taking it or taking too much, you need to cover that. There are other reasons for hypoglycemia other than insulin, so you need to be aware of that. Any questions that you had? It kind of was just to kind of, I know most of you probably came up with whether it was hypo or hyper. Also, most of the lists, if those of you in different groups look, the hypo and the hyper, remember, a lot of those are exactly the same. It's knowing which ones are different, right? So slightly elevated heart rate, both of them. So your vital signs, not going to be worth a hill of beans. So especially because even if your temperature is slightly elevated for hyperglycemia, it's only going to be like 98.1. It's not like it's going to be anything, and they could run that anyway. So don't count on just things that are objective. This is where you really need to get into the subjective data. Yeah. Yep.
For just like, is there times when it doesn't matter whether it's too much or too little medication? Because like on the slideshow for hypoglycemia, it was too much diabetic medication, but in her case, she forgot to take it. So is there certain instances for that?
I can't think of anything right off the top of my head, but what I would want to know is when's the last time you ate, what did you eat, and what is your medication, and when did you last take it, and how much, okay? That way, no matter whether they're type 1, type 2, ate too much, ate too little, or whatever, as a nurse, you're kind of covering all the bases, okay? So, what and when for both? What kinds of medications? I mean, if they're taking aspirin or if they're taking Detamir, you're going to do totally different things, right? So it's kind of also asking, has this ever happened before? So that you know, is this like something, we really need to dig in on, is her body changing? Do we need to get her back in with the diabetic educator or the dietitian? Those kinds of, if it's happening all the time and there's no reason, right? Then it's like, then we really need to investigate further, okay? Anything in Rochester? So for this next part, we're going to hand out the case studies. You have to go in to the ADA that's on your website, the Standards of Care, American Diabetics Association. You're going to be looking specifically for information. You can use some of the information off of the PowerPoints, but particularly when you're looking at the range of A1Cs, you're going to have to look in the ADA. So if you have questions, Lindsay, when you get those out from students, field them my way and we'll do what we can to get them covered. Otherwise, I'll see you guys in about a half an hour and we'll go over the answers. All right. All right, let's play. Very cool. How's it going in Rochester? So for question number 2, make sure that you use the ADA standards. Look in the table of contents under glycemic targets or glycemic goals. And there's kind of a purple box there in that chapter that'll give you all the recommendations. Write them all down, except for about the pregnant lady whom I don't care about. Somebody else will teach you about that. Okay? And if you have problems or can't find it, shoot me a look. How's it going in Rochester? Do I have a look? Confusion or excitement? Okay, I'm going to give you guys a hint because I'm not there and I can't go around and look. In your ADA standards of care should be on page S58, S59. There's a purple box, and in that purple box are some recommendations. I see some people going, yoo-hoo, got it, got it. Okay, so I want you to know all of those, okay? Because on a test, which is coming up, you will find questions that have to do with that. So you might get, you have a healthy 28-year-old with no comorbidities, there we go. What would be the optimal recommendation for her A1C goal, okay? So know them all so that you can answer those right and get the points, okay? Okay, guys, here in the cities and in Rochester, even if you haven't finished, let's come back together. I'll go over some answers. I might ask your groups for some thoughts. Like Rainy, so I can call on people because that's super fun. And what I said here in the cities, if you have not finished it, make sure that you do take time to finish it on your own. You will see questions like this on the next exam. So the more that you kind of practice that and really think about it, the better off that you'll be. On your ICAs, if you put your name and all of that, and I might just give you a minute to do it now, I would like 2 things that you learned today that you think will help you in your practice. And if you'll do that, I'll give you like a couple minutes and then we'll finish out with the case study. Okay, let's jump into the case study here. We don't have time to go reread it all, so I'm just going to say for question number 1, how about Taylor and Ashley in Rochester? Would you like to give me some information that you wrote down on your sheet? Taylor and Ashley?
Ceiling mics are on. You're good. Yep.
Well, she has a history of type 2 diabetes.
Just speak as loud as you can.
She has a history of type 2 diabetes, and her weight is according to the BMI, it would be obese. And then she has a lack of exercise, which is under 30 minutes a day. And then her HbA1c is high at 7.3%.
Okay. Anybody else there in Rochester have some additional things that weren't there? How about hearing this? Oh, somebody in Rochester?
No, I don't think so.
You guys. Okay, here in the cities, anything that you didn't hear? So there's lots and lots of stuff there. So obviously the hemoglobin A1C, blood sugars, the blood pressure. Remember that diabetes is the leading cause of cardiac disease and stroke. So blood pressure does play into this as well. Elevated BMI. One thing you have to remember is that pertinent information can sometimes be positive information or information that you're looking for, but it's not necessarily high or low. So one of the things here is that there's no loss or gain of weight, okay? That's good information to know, right? Dyslipidemia, hypertension, non-compliant with diet. Sensation on feet is intact. So that's a good thing, right? But it's a really good thing. It's something you want to know. You have an opportunity to step in here and help her. Some of the medications that she's taking, minimal exercise, denies polyuria and vision problems. So that means that she's not maybe experiencing hyperglycemia, at least right at this point. So just remember, you want to look at all of those things, even if they're not necessarily abnormal. They have to do with diabetes. So you want to know good, bad, ugly, okay? What are the recommendations for target hemoglobin A1C? List them all. So I think you guys all found those. Just remember that for people who have comorbidities, or if they are older and have comorbidities, it's not necessary to have them have a hemoglobin A1C of less than 6.5 or even less than 7, right? A hemoglobin of 8 would be acceptable because we know that we're not really trying now to prevent those long-term complications because they're not probably going to be with us really more long-term. What we really need to do is prevent hypoglycemia, okay? So we really need to be careful there. So I'm not going to go through all of that just simply because everybody did find it, right? Okay. So number 3, the assessment of this patient's data. I think it's good to not only just find the data, but figure out what's important about it. So let's look at Shannon and Hannah. Why don't you guys give us a roundabout there?
We thought she could be doing a better job of managing her condition. She's made some improvements, but she could make some diet and exercise changes in particular to help lower that A1C.
And I think you're absolutely right. Anything else? I think that really was the gist of it. Let's go on. Recommendations for this patient. Let's look at Rochester. How about Maggie and Stacy? What do you think we're going to do for this patient?
For nutrition?
Okay, nutrition, absolutely. What else?
Do you want to get specific on all of them or just one?
I didn't maybe understand the question.
So we're
Do you want them to answer all of them or just one? On nutrition, exercise, sick care?
Just one is good.
Go for nutrition.
So nutrition,
Limit sweetener.
reducing. She says that she has multiple servings of sugar, so making sure that she's reducing sugar intake.
Okay. How about sick care? Anybody want to take that one? Okay, here in the cities, let's look at Mandy and Morgan.
Check the blood glucose every 4 hours. They need to initiate insulin treatment. They need to eat while sick and increase fluid.
Okay, good. So I can see that our time is limited, but if you haven't filled all that out, it's important to do so. If you please bring your ICA sheets up here in the Twin Cities and make sure, set them on Juliana's desk. And in Rochester, make sure I get your ICA sheets so I can give you credit for being here today. We'll see you next week. Lindsay, you're a rock star. Thank you.
A lighter fight.
I know, I have that's really good.
Where are we going, Styles? Applebee's?
everybody.
I'm literally so done with it.
No worries.
All right.
No, I'm not gonna.